not yet silenced your phones, if you could do that, that would be greatly appreciated. If anybody needs a paper copy of the evaluation, wave me down at some point and I'll make sure you get that. Otherwise, join me in welcoming Dr. Virma, who is going to talk to us today about anxiety, and she comes to us from Rogers and is a child and adolescent psychiatrist.
Good morning. Hi, thank you for coming up today. It's pretty good attendance. So yes, as Laura just mentioned that I'm Shikha Verma. I'm a child and adolescent psychiatrist working with Rogers Behavioral Health. And my primary practice area is in Kenosha, Wisconsin. I used to be an inpatient physician for 3 years in Milwaukee, and then I moved to Kenosha for the PHP, partial hospitalization and intensive outpatient programs. So today I'm going to talk about anxiety, and we all see it, and I really wanted to thank you all, first of all, for what you've been doing, because a lot of our referrals at our level of care are from school. So it is commendable for whatever you're already doing, but that is why I wanted to bring it a step further for how the school counselors and at this level you guys could help these kids more. In recent years, I've noticed that some of the school districts have even started having their own therapists within the schools. And this is a new trend, probably to destigmatize the mental illness, bringing it to the doorsteps where the kids actually are and spending most of their time. So this is all lovely, and that is why I wanted to bring it to what are the warning signs, when is it not normal, and when do you intervene? So here we are. I have no financial disclosures, and the objectives are identifying what is normal and then what is not normal. And between that normal to abnormal, what are the risk factors? What predisposes them to move from that normal anxiety to abnormal? And in the end, I will be talking about how we could be intervening at various levels, at a child, like when they are extremely anxious, or at parents' level, and then what school counselors can do, how they can assist, helping this child get the level of services that they need. So we use words anxiety, worries, fear interchangeably a lot. And I first of all wanted to stress upon the fact that worries and fears are not the same. Worries plus fears does come up as anxiety, but they are separate aspects. Worry is more the apprehensive thoughts about negative future outcomes. And usually the content and complexity of the worries tend to increase as the child grows. However, the fear is actually perceived as an actual threat to an existing danger, like thunderstorms or tornadoes. It's a real fear that somebody can be struck by a thunderstorm, but it's not necessarily a worry. But when it is enhanced to the fact that it is beyond the normal, when it is over, when they are ruminating, when they're having the overwhelming thoughts that they cannot get rid of, then it becomes more of a fear. And then that's why we say that the fears decrease as the child grows in age normally, and the worries tend to increase because the complexity of the thought process increases while they're growing up. So we do have normal developing worries and fears in children. Everybody has it. So in their toddler years, they fear about the imaginary creatures, monsters. When it is age 5 to 6, they worry about their physical well-being, the boo-boo stage of their life, where every injury needs to be taken care of. Then at age 8 to 13, and younger ones around 8-ish, 9-ish, because the finality of life starts becoming more clear. That is when they start worrying about, if I can die, if my family members can die, And while they are growing up, they start worrying about the behavioral competence. Will I be accepted? Are my fears accepting enough? Are they evaluating themselves all the time? And then the psychological well-being as well. So why I was saying that fear and worries are different, because fear and worries originate in different parts of the brain. So fear is more associated with the amygdala centered circuit. Amygdala is a part of the brain, and then the worry actually comes from the corticostriatal circuit. Fear leads to panic and phobias, and worries causes the anxious misery. The apprehension leads to the social anxiety. The apprehension and expectations and leads to generalized anxiety, and then the obsession. So they all fall in that spectrum. So they are originating differently, their course is different, fears are going to decline and worries are going to increase, but they all together, when they are beyond the normative years of lifestyle, they become a disorder, anxiety. So this is a very important slide, and I didn't want to put in a lot of words in there, I just wanted to keep it simple. That's how anxiety presents. The physiological arousal, what does that mean? When somebody is having nausea, when somebody is having stomach aches, headaches, because they're so anxious, when they're having cognitive distress, they are shutting down, or what you'll see probably sometimes is in younger kids, temper tantrums, behavioral outbursts when they're having those, right? And then the behavioral avoidance, that's the last aspect, when the anxiety is so profound that they don't want to come back to school. They want to avoid the circumstances and situations that is making them feel that way. So I want you to understand that you guys probably see this a lot at school, from every level. You might have a child sitting in the nursing room almost every other day that they're having stomach aches. I'm not saying they could not be having medical issues, of course they can, and it should be ruled out. But if it is anxiety, please don't dismiss it. The other is, when you're seeing the temper tantrums, just don't see them as they're defiant. They don't want to listen. There could be a root cause different than what is causing the irritability is more important too. So making them talk about it. And then the behavioral avoidance, when they are avoiding coming back to school, when their functioning is impaired, when they're not able to, proceed as to the best of their intellectual capacity, then what do? How do you bring them back to the school system and facilitate their education? So anxiety disorders are clumped into a lot of different categories here. I wanted to highlight the bold red ones are the ones that you probably see the most in school. And then the lighter ones are probably, once in a while you'll see those. I see them a lot, but my population is skewed. So I wouldn't, I wouldn't say that that is the normal frame of the actual incidence or prevalence of those anxiety disorders. And the last ones, you probably don't get to see them. So I am going to stress upon on all of these. While I'm saying that, I would also like to say that obsessive compulsive disorder, OCDs, were removed from anxiety disorder component alone from the DSM-5. So when the DSM-5 was created, OCD and PTSD, actually both, were removed. So now these are the ones that are left in the anxiety disorders. So what do you think I'm going to talk about next? Separation anxiety disorder. Probably the faces won't be as happy though. But the situation is going to be similar, when the parents are dropping them off early in the morning, The separation anxiety disorder is when there is inappropriate and excessive fear, anxiety concerning the separation from whom they are attached. There's a recurrent excessive distress whenever they are anticipating that the attachment figure is going to go away. The other worry, the biggest worry, is that they're going to lose them. Either they will meet an untoward effect for themselves, or parents will meet some disaster or something while on their way when they're coming to pick them up and stuff, and then they don't want to let them go. Then there could be some physiological arousal where they're having some nightmares, and where when there are other physical symptoms including headaches, stomach aches, nausea, and vomiting. So if you see those three big bullets that I did there, It all includes the slide, the tripartite anxiety model I was talking about, the physiological arousal, the behavioral avoidance, and the cognitive distress that a child is experiencing. The fear and anxiety should last for at least 4 weeks. Those separation anxiety that you guys would see at school in the mornings should continue at least for about a month or so to be able to give them a diagnosis. So one time, a week time, early on in the year when the school year is beginning, that's not when we tend to diagnose them. We let them adjust. We understand that there's a transition phase with every school year, and it can happen in younger kids. Then the fear. Can someone tell me, like, when is the separation anxiety normal? I'm sure a lot of you have kids, grandkids. What ages do you consider separation anxiety to be normal? Louder.
2, 3, or 4.
So anywhere between, I would say, 8 months to 3 years, 2.5 years is when it is considered to be normal. So if you are seeing it in a 5 and 6 year old, they are beyond the age when they should be having those symptoms. Okay, and it tends to decrease from childhood to adolescence. So clearly, if you're seeing it in somebody who's 13, that is not normal. So there can be social withdrawal, they could look sad, they might be apathetic, there could be difficulty in concentrating, they might be homesick, they might make excuses to come to school, and there could be some perceptual disturbances, experiences. They might be angry and throwing tantrums at school, and you guys might get involved, because a child isn't behaving well, and how do they need to address it. They may come across as demanding, intrusive, and needing constant attention. But again, don't label them with defiance. Don't label them. Try to figure out why they are being that way. They're too young. Usually when I see separation anxiety, they're usually around 5, 6 years old, and they're too young to be manipulated. Yes, all kids learn triangulation, splitting between parents and stuff quite early in their lifestyle, but they are still too young to be having that level of complexity that they are trying to be demanding when they are anxious. Specific phobias. This is about fear or anxiety about a specific object. Again, there is a phobic object or situation that causes imminent fear or anxiety. The phobic object is actively avoided to endure the intense fear. And the fear and anxiety is out of proportion to the actual danger. The symptoms here should last more than 6 months to be labeled as specific phobia. So if they go for their doctor's visit one time and they ran out of their office because they didn't want to get poked, and that was a one-time occurrence, they don't get diagnosed with specific phobias. Okay? And if there are any specific targeted phobias, then you have to specify in the diagnosis to what is it related to. I am talking about diagnosis here because I already know that most of you know how to screen for anxiety. I want you to be able to identify and get them the help, when you see the pattern and what needs to be done and how can you work with the parents. So please let me know if there is anything that you would like me to focus on more, if we have some time remaining. This is the best I could do with my graphic skills. So what am I going to talk about next? Exactly, generalized anxiety. So this is worries, fears, anxiety about various triggers. They could be worrying about school, they could be worrying about their sports activities, they could be worrying about their peers. And all happening at the same time. The individual is difficult to control their anxiety. Many times with generalized anxiety, the older adolescents tell me that they cannot go to sleep because they cannot put their thoughts to rest when they are trying to go to bed. So their thoughts are so overpowering that they are not able to sleep. Yes, along with not sleeping, high anxiety, they are going to act out at school. Right? So there should be 3 or more of the 6 symptoms, and kids only need 1 of the symptoms, like they're being restless, feeling keyed, being on edge, fatigued, having a muscle tension, difficulty concentration, and sleep disturbances. The distress should be significant enough. This distress should cause social occupational functioning. What that means is they're worried, they can do it, they can function, but they are not able to function. Okay, so you might have seen somebody was scoring straight A's last year and they are flunking all their classes this year. What happened? They clearly, their IQ did not drop from 130 to 70 this year. So there must be a change, and finding that change is important. Seeing those patterns are important. And because you guys have those kids for years and years, you guys are probably able to identify it a lot sooner than anybody else. Panic disorder. So panic disorders are unexpected panic attacks with abrupt feelings of intense fear and discomfort, which reaches peak in minutes. And they either have dizziness, fainting, they have increased heart rate, choking sensations, they're not able to breathe, they're trembling. So a lot of physical symptoms, nausea, abdominal pain, they all can happen. But remember, they're unexpected panic attacks, not related to the situation. And why I'm stressing on that word is, if somebody has worries and fears about everything around them, labeling them for generalized anxiety disorder, and the panic attacks are occurring from those worries, the diagnosis should be generalized anxiety disorder with panic attacks. You would not give them a separate diagnosis of panic disorder on the top of generalized anxiety disorder. But if the panic attack, so what I'm saying is, when it is happening with another anxiety disorder, try to club the diagnosis, and when it is happening independently, that's when we give them a diagnosis of panic disorder. That's the difference. So the attacks are followed by a month of one or both of the following. There's a persistent worry about having more panic attacks when they're not having any. And the next one is that there's a significant amount of change in their behaviors from those attacks. The agoraphobia, there is a marked fear or anxiety between 2 different locations or situations. They worry about open spaces. They worry about being in enclosed spaces, or when they are in crowded places, transportation. The individual fears or worry and avoid those situations, and it causes intense anxiety that they are not able to control. And the fear is disproportionate to the actual danger. What's next? Social anxiety disorder, exactly. So the social anxiety disorder is when they worry about being judged, when they worry about being scrutinized all the time. They worry to tell people that what could be making them anxious, because they worry that they will not be accepted, that they will be rejected for who they are. And then there's such a significant personal distress that they start avoiding all those circumstances. Again, the symptoms should last for a good 6 months or so to get the diagnosis. And when the anxiety is about performance only, when they're not able to do presentations and stuff in the classrooms, then you give them a diagnosis, performance only, social anxiety disorder. Selective mutism. I think I was just talking to you about selective mutism just now. Selective mutism is one of the only anxiety disorder that occurs primarily in kids less than 5 years of age. Okay, here kid fails to speak in particular situations, so either at school or with friends. But what we need to know is that they shouldn't be getting that diagnosis if they don't know the language, and that's why they're not speaking, or if there could be any underlying communicative language disorders that are not identified. Have I seen selective mutism? Yes, I have. Do they progress well? Yes, they do. What are the risks for future kids who have anxiety to the extent that they are led to selective mutism early on in their life? They could have other anxiety disorders even when selective mutism subsides or fades away with time. So they are at higher risk for anxiety disorders in future. So if you have somebody at school who is having selective mutism, you can expect that even when the selective mutism starts getting better, that child might be just anxious at the baseline for, yeah. So one thing I wanted to mention here is that we do use the selective mutism questionnaire, and these questionnaires are completed by parents and teachers. So, and we like to monitor the progress of the child through these questionnaires. So when you get those questionnaires, like we being the psychiatrists really appreciate any of those feedbacks, because after parents, you are the best people to know these kids. So we really appreciate how they are developing. When we are trying to implement the therapies and strategies, we really want to know if they are progressing or not. So this is not included in the DSM, but this is such a huge topic that I wanted to touch base on it today. So school refusal can happen from a variety of psychiatric disorders, between separation anxiety disorder, generalized anxiety disorder, social anxiety disorder, MDDs, and oppositional defiant disorder. Both negative reinforcement and positive reinforcements can be contributing to school refusals. Do we understand what negative reinforcement and positive reinforcements are? Okay, so it's basically from the operant conditioning model where when you take away something and it improves the behavior, that is negative reinforcement, and when you give something as a reward and the behavior improves, that is positive. Every time a thing is taken away, that is negative reinforcement or not, but if the behavior is improving, it is reinforcement. Okay? So there are 3 types of school refusals: anxious, truant, and mixed school refusers. Prevalence is 1% in all youth and 5% in clinically referred youth. The peak that I see is closer to 5 to 6 years, and the second peak that I see actually is for the high schoolers when they're beginning the high school, but sometimes around middle school as well. Some kids would start working and not going to the schools. The comorbidity could be that 25% of the anxious school refusers have at least one other psychiatric disorder. So there could be more than one involved. Depression is most common, but separation anxiety disorder and school phobia, social anxiety disorders also lead to the school refusal. What are the subtypes? The subtypes are, there could be anxious type, truant type, and mixed type. So not all school refusers are anxious. There are other causes too. Sometimes, and what are the risk factors for that? Like single parenthood is considered as a big risk factor. If the environment is dangerous, it can cause anxiety in the child themselves. If the parents have psychiatric disorders as well, it can also cause modeling behavior for the child to be anxious and leading to school refusals. Truant youth have usually minimal parental supervision. The parents have had kids at a younger age, and they could belong to very polished homes. And the mixed type have both the features. The family dynamics that are known to play a bigger role here is that there could be enmeshed and conflictive families. And sometimes we like to rule out, we try to give them the family environment scale and see that what could be causing those school refusals. And then with the disengaged and rigid families, we like to score their family adaptability and how cohesive they are. 81%, this number is fairly high, and it was very difficult for me to believe that 81% of the parents had a history of psychiatric disorder, so you might need to assist a lot more, in not just the child alone, but how do you help that parent as well. How do you prevent? What's the course? What's the prognosis? Extremely important. Promote the healthy family relationships, encourage the independent behaviors, work on the problem resolution, and then try bringing them to school as soon as possible. Only 25% remit spontaneously. 75% do have negative outcomes leading to decreased likelihood of advanced education, social isolation, and job difficulties. So a pretty big chunk of school refusing kids might not do well if not adequately treated. How do we evaluate? Mostly it is a clinical diagnosis. We do school refusal assessment skills as well, which assesses them at 4 functions: that they are avoiding the school behavior to avoid the negative affect, escaping from the negative social interactions or the evaluative situations, getting the attention. That is a positive reinforcement in a negative way, getting the attention from the others when they shouldn't, and receiving the tangible reinforcements when they are not in school. What is the treatment? Primary treatment is cognitive behavioral therapy. You want to work on cognitive restructuring of these kids. You want to work on relaxation and utilizing the social skills approach. The second is, and this is extremely, extremely important. I wish I could just take this mic and walk there and say, plan on building the hierarchy. How are you going to bring that child back to school? If it is acute school refusal, just started now, please try to bring them back to the full day immediately. Okay? But if you're seeing chronic school refusers, you might have to build on the hierarchy. Hey, today I'm going to walk you in the hallways. Walk with me. Tomorrow you're going to walk alone. And tomorrow, the following day, you're going to sit in a study hall. And next day, you're going to go to your classroom and come back. Building that hierarchy and facilitating. There are times with the school refusing kids, I have asked to, let's do 1 hour a day at school for this week. Let's increase it to 2 hours next week, 3 hours the following week. But we have to work really closely with the school counselors and the teachers to implement all these plans. And it can't be possible, if you guys aren't involved and not able to accommodate those needs for the kids. Parents need to be learning to set the limits, and teachers and counselors should have a plan to reintegrate the school. So what I'm trying to say is, a lot of times when I am treating the child, they're not going to school, either parents decide, or the school and the parents decide together to change the school, or they decide to make it all online. When you're taking all that social interaction away, you're just making that anxiety worse. It's not going to get better. When they move to a different school, the cause is not treated, and they are going to be more anxious in a newer environment, and that is going to continue. So how many schools can somebody change in a school district? So. The medications are a last resort in school refusal, and mainly when we identify that it is coming from a true anxiety disorder, and they're so anxious that even for them to be able to participate in that hierarchy or that therapy, they need to calm down those nerves before they are able to integrate those plans. The triggers, predisposing, and risk factors could be, we psychiatrists love doing twin studies. We just absolutely love it. Okay? And that is considered as one of the biological risk factors, that when a parent has anxiety disorder, we expect that the child will have a higher likelihood. If a child has an early onset of anxiety disorder in their life, it is likely that their anxiety will be more disabling as they're growing up. And the third is that if a twin sibling has anxiety disorder, genetically, they will be at a higher risk. Child temperament. So behavioral inhibition, what that means is when a child is shy, extremely shy and very introvert, that also is considered as a risk factor for the anxiety disorders. And the environment contributes too. If, as I was just mentioning earlier, anxious parents, children can model their behaviors and fears and anxiety. The overprotective and over-controlling parents, a lot of times kids feel pressured to do better because parents are being very overbearing, to say the least. And then there are sometimes insecure attachment and figures where it can transmit to the anxiety disorders in the growing child. These are some of the skills that we use. And scared is the one that I use the most. There are various forms of scared, but 41 questionnaire is reasonably long enough and still brief enough that it can be completed instead of those MMPIs, which is 575 questions. So, treatment. Not that you guys get involved a whole lot in that. I just wanted to mention briefly to you guys that multi-model treatment approach is the recommended treatment. Anytime a child has mild to moderate anxiety, we want to make sure that they get therapy first. Medications is not the first line. When the anxiety goes from moderate to severe, like I said, you want to make sure that they have some meds on board so that they are even able to participate in therapy at that point. When risk factors come in, like suicidality, it trumps everything else. And you want to bring medications and stabilize and then work in therapy. All the anxiety disorders, cognitive behavioral therapy is the very effective modality. In Raj's behavioral health, we do the anxiety OCD programs, where in CBT approaches we apply the exposure response prevention therapy as well, where we develop the hierarchies, we work on the hierarchies, and that's how we bring the kids back to the school. PCIT is parent-child intervention therapy. It is mostly done for younger kids when there is concern that parent and child interactions could be contributing and they are not therapeutic for the child and could be contributing to the anxiety disorder. I don't know if any of you have seen that kind of a therapy here. Here a child and a parent is left alone in a room, and the therapist actually is outside the room behind a one-way mirror. First, child has, it's a child-driven session, then it's a parent-driven session where there's a microphone in their ear, creepy, right? And the therapist is giving instructions from outside how to respond to what child is doing, and that's how they are coached. During those times, systemic desensitization is when you give them the skills and then you club them with their hierarchy of anxiety so that they can work on it. Then the interoceptive exposure is, we sometimes are pretty bad guys here. In panic disorder, sometimes when no other therapies are working, we have tried doing interoceptive exposures. What that means is we actually induce hyperventilation in the child or make their heart rate go faster by physiologically making them run on the treadmill until they realize they're not going to die out of it. So just explode them with the exposure, and then it is expected that eventually their anxiety will come down, because it's a spinning cycle of anxiety that's going to go higher, 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 and then your brain is going to say, check it, I'm not going to die out of this. And then the anxiety will start coming down. Selective mutism, extremely important. Most of this is done at the school levels, most of this. You start with the nonverbal communications, any gestures are rewarded, then you start introducing the verbal skills, and then you start doing the behavioral interventions, any social interactions are rewarded at school. Then you reward the communication with the hierarchy. Let's say they're able to write down what they need, you want to reward them. And as I said earlier, we should make sure that they're not having any communication language deficits. Please target those as well if they are identified. And the adults should not speak for a child. But that does not help the child actually. And then stimulus feeding. Stimulus feeding is when child is able to talk in front of one of the caregivers. You want to include them at school in the classes sometimes. And then slowly, when they start speaking a little by little, mom is going to sit outside the classroom, then mom is going to go away, sit in the parking lot, and then she will not be there. Okay. So So when they did the RUP study is one of the studies that they did on kids with anxiety disorder. They found out that the combination treatment is actually better between medications and the therapy. For specific phobia and selective mutism, these are the two that medications are the last resort. You know, in other aspects, the combinations were found to be better. So these are some of the things that I already talked about, what they are. Any questions? Please go ahead.
Because CBT is the preferred method in treatment, what in schools can be given to schools to help them continue the CBT success?
Great question, and I'm going to come to that very soon. So let's talk about CBT because I said so many good things about it. It works if done correctly, and it works if it is continued after the therapy. Sometimes when people tell me they've been in therapy for 3 years and nothing is getting better and that is why they're here, I tell them, what were you doing? Like, you know, therapies are session driven. CBT is usually 16 to 20 sessions. If somebody is in therapy for 3 years, highly it is unlikely that they had the goals that they were working on, you know. So after a while, it becomes more of a dialogue, talk therapy than the goal-driven therapy. So cognitive behavioral therapy has behavioral interventions and cognitive restructuring component. You can do graduated exposure or you can do intensive exposures. Graduated exposure is through the classical conditioning paradigm, and what that means is Pavlov's famous experiment where food is paired with the bell and it produces salivation, and then when you keep doing that, and even when you take away that food and you ring the bell, dog is still going to salivate. That's the classical conditioning. The operant conditioning, as I said, the rewards are intermittent and unexpected, and that is how you reinforce. So all the extinction models, habituation, are a part of operant conditioning. Extinction model basically means that they are, you're going to pair a negative behavior with a stimulus, and then you will not continue to reward it. And the longer you go that way, that behavior that they were doing is going to fade away. It's going to extinct. The habituation is that they are paired to the extent that the behavior isn't rewarding anymore, and they are habituated with that response. Cognitive restructuring is a lot of depressed and anxious kids actually struggle with negative thinking, negative over-processing. And I talk to them a lot about how you have to associate this as a part of your disorder and not you. So when you are thinking, I am not good enough, you know, I can't even talk in my school, I can't even do a presentation, then say, this is my anxiety, and how do you turn it around? You come up with the negative statements to what you just said. I'm not good enough. Then you come up with a statement, my friend just told me I'm fabulous. And what are the reasonings for that statement? You know, you come up, I helped my friend, I got them through the situation. So that is how you turn around that every negative statement that they say into a positive one. There's an automatic negative thought process that involves with the depression and anxiety disorders that we want to work on through CBT. And then contingency management is, how do you say that? You do this for me and you're gonna get 10 minutes of TV. Like basically tangible rewards. You do want to involve families extensively, and that's where your role comes into. Child should not be made into a sick role here. Involving families is important. It is in multiple studies it is found that when you're doing CBT with a child, adding a parent component make the child get better. If parent has anxiety for themselves, then adding therapy, parental anxiety management, along with child anxiety, makes them better. And then family therapy. Family therapy is essentially, as I said, the center is not the child. You're involving everybody in the family. And again, I'm saying all this to you guys. I don't know how much you guys use it now or how many of the schools already have existing therapists at school levels. But if some of you do, like, it can be very important to see when you see a child is anxious and you see a parent is anxious too. It is important, reflective question. You kind of seem tense. Like, are you seeking help? Are you getting help? Just reminding them that how your own anxiety could be modeled in the child as well. A reassuring statement from a parent is so much more helpful than anything else that can be done for the child in the moment who's anxious. But if the parent is anxious themselves, the child is going to fall apart. So how are we going to assist children and adolescents, especially when they are in school or when they are anxious, when there is a high anxiety moments and when they are in therapy and in treatment, talking to the families what helps them? If there are fidget toys, which are not disturbing the class milieu, of course, can they keep like small squish balls? Schools have accommodated that. Like, when we discuss with the schools, they are able to accommodate those. Can we do some positive reinforcement, like, charts, systems that most schools follow? Then contingencies. Excuse me. If there are coping skills like deep breathing or muscle relaxation, and parents have told you that, maybe just reminding the child in the moment that, hey, mom told me you do this, you do it really well, do you think you can use it right now? For adolescents, those reward contingency, they don't care for that. So doing the other factors like the positive reinforcement, encouraging to talk about anxiety, taking a break, but the break should be small. Mindfulness, we all know what mindfulness is. Being in the moment, staying in the moment, being able to ground ourselves, checking our breathing, checking where we are. Then coping ahead. If they expect that they're going to have a presentation today, they're going to be anxious, could they work with their teacher in the at school? I'm really nervous today. This is what I want to do. What can I do? Planning ahead can help them relieve the anxiety as well. In long term, we always ask kids to get adequate sleep at night. The disturbed sleep contributes significantly to how good they're going to feel about themselves. Then adequate nutrition, then psychotherapy, and if medications, if they are taking them or not. A lot of times I have to say when parents are inconsistent with administering medications, I have asked schools to get involved. The school nurses are dispensing medications because when a child takes medication 3 days out of 7 days, I worry more that they're going to have side effects than benefits from the meds due to non-compliance. What parents can do, avoid the accommodation. As I said, it is a natural instinct of a parent that they want to rescue their child, but reminding them in the moment that you're not helping them. Don't talk for your child, allow them to express themselves, and do not dismiss their feelings. When they are anxious, don't say, watch a movie and get over it. Acknowledge their feelings, use the word of encouragement. I know it is really difficult, but I know you can do it. Then set the realistic expectations and follow through. Second part is where I struggle the most with parents. I was in a family therapy meeting last week and I was telling them, I really think that the child should be able to ambulate themselves. There is no neurological cause why the child cannot do this. You need to stop wheelchairing them in and and every single morning I saw that still the same thing was happening. They agreed to us in the family meeting and not being able to follow through is the most difficult component. Positive or negative, child seeks attention. And being in that sick role is perpetuating that child's problem of not being able to, hey, my mom is able to do this, why will I do that? They can drive me around. I am 17 and a half. How does it matter? My 20-year-old brother is at home, so can I be once I'm 18. Those were my communications and discussions with this child, adolescent. identify your child triggers. That's my another statement to the parents. Like, you know your child best. Know what the triggers are. If giving too much information makes them anxious, give them the information right before the event is happening and take them to the event. But if sudden transitions make them anxious, prepare them. Then coaching the breathing to the parents, then mindfulness and positive statements, coping it, all that in long term for the child works for the parents as well. Long term, this is my favorite, the first one, monitoring screen time. I have had kids who are spending 10 to 12 hours on screen. The American Academy of Pediatrics recommends less than 2 hours a day. We talk about the blue light, how stimulating it can be to the brain. So we want to avoid all that. Then engage the children and adolescents in other recreational activities. If they have too much free time, they will be watching TV, right? They will be on their video games. Acknowledging the anxiety and then reassuring in a long-term basis. If the concerns are physical symptoms, like I said before, yes, do rule out the medical possibilities, that if the physical symptoms are happening from an actual medical ailment, but if it is not, then please validate. Child could be frightened, fearful for what they are experiencing, but then turning it around and saying, I know you're having some stomach aches. Remember how the doctor had said that there isn't anything wrong, and that's a good thing, right? But we gotta do this. Then managing your own anxiety at the time. So here is what we were going to talk about. In the ongoing situations, talk to the families. Please don't call out. If you know someone gets anxious, don't call out that person. Don't put them in the spot. Talking to them in person before the class begins, saying, today is your turn to read this chapter, and I'm going to ask you, but would you like to take a minute before I do that? So I wanted you to be prepared. I'm just going to ask you what's going to help. Maybe reading alone before they read in front of the class. So suddenly, don't call them out. A lot of attention focused on them, like I told you guys in social anxiety disorder, they can do it. They just won't be able to do it because there'll be a cognitive distress, there'll be physiological arousal, and then their mind will avoid with what they wanted to do. Okay? Then identifying the triggers with the families, developing the plans with families and teams, and then utilizing how you could stay calm in that moment. Validate, but yet normalize. I've said it repeatedly, timely. Never say, okay, I know, we always have this. Every day you get anxious this way. I know social situations are difficult for you, Mark, but I think we have to do this so we could do this, right? Like normalizing is extremely important. Everybody feels this way when they have to present, and I am sure you are too. Can we use some skills right now to calm you down? Rephrasing, restructuring, still giving the same message and still upholding the expectations that the child was supposed to be doing. The more you accommodate saying, okay, this person is not being able to present, maybe you can just present in front of me when the rest of the class isn't around, you are taking away the social anxiety component. If there is a plan, if there's a secured plan to move them ahead, you can present in front of me today. Next week's presentation will be in front of 2 of your best friends and me, and the following week will be, thank you, and the following week will be like, maybe in front of 10 kids. That should be the plan. But if we keep doing this, that yes, you and I can just do the presentations, we are not helping them succeed. Then reminding the students about the skills. Breaks are allowed, should be provided, but they should be small. And then encouraging them to do all the exercises. And here, you need to talk to the parents, what works for them. And that's what you need to bring to the classrooms, being prepared. I think being prepared is extremely important. It is very easier for me to say it than actually do it, because I don't know for the 24 kids in the classroom how prepared a teacher can be. But if there are certain identified students who are struggling, maybe at least for a few of those, if the teachers could prepare themselves, if the counselors could, and then returning them back as soon as the anxiety moment is over kind of helps the facilitating the process. And in long term, please encourage, when you're identifying the students that they are struggling with anxiety, please encourage them to seek help. If they are with school nurses with vague physical symptoms and no medical cause found, acknowledge, say, yes, they are frightening symptoms, but you're okay. We will be able to do this. Same messages between parents, and the message should remain same between parents and you. If you guys are poles apart, child will be confused. Then avoid contacting parents for a social anxious care when they're asking, can I call my mom? Can I call my mom? And you know that this is anxiety driven. Don't ask them, yes, you go ahead and talk, because then it is again positive reinforcement. You're letting them have that reassurance, external reassurance, than an internal to calm their anxiety. Okay? And then avoid sending the children home when they're having social anxiety disorder. As I said, they're not going to die. There is no physical ailment, actual physical ailment. So please don't reinforce. The positive reinforcement, the negative reinforcement here is you're taking away the trigger that was causing anxiety by sending them home. And the positive reinforcement that I see most of the time is they go home and they watch TV because parents are busy. So there's a double sword why they will not be coming back to school. And then supporting and guiding the parents in managing their own emotions. I think you guys probably see it a lot more than I do, almost on a daily basis. And you guys are and people like mine, go-to source. How are we going to make this child successful? So important points are anxiety is an internalizing disorder, and children may be more aware of their own inner distress than parents or school counselors or teachers. Parents and teachers can underestimate the severity and impact of anxiety, but what parents and teachers see the most is how severely impacting is the anxiety in family dynamics, in their school performances. So they see the effect, but they don't necessarily recognize how bad, how severe it could be, hampering it could be for the child. So these are some of the resources that I really like. What to do when you are scared and worried. Your anxious child, how parents and teachers can relieve anxiety in children. Coping CAT workbook, I like it, but I really do not know how much you guys can utilize it in your settings. We do it therapeutically in our clinics, in our partial programs, but I'm thinking if you guys have any existing therapy models, you guys can use it there as well. Then there's a parent version as well, and then CAT project workbook is more for the adolescents. The coping CAT workbooks are for the younger kids, and the CAT project workbooks are for the adolescents. Any more questions? Hi.
Do you have any suggestions specifically related to avoiding eating due to a fear of throwing up?
Avoiding eating with the fear of growing up. Are we talking about the specific phobias towards eating?
Just in general, if the student consistently kind of has worries across the board, but then had gotten sick at school one time, and that was like a big trigger.
Emetophobia is how if a child has episode of vomiting, after eating or being in front of somebody, they develop this phobia if they're going to have emesis when they eat at school again. Again, we do CBT for the same as well. What could you do? I think there are times when we have facilitated child eating alone in that. important is to realize we are not having any eating disorder behaviors there. Like, if they are worried that they're going to eat and they're going to get fat, that's a whole different animal and it should be addressed differently. But if it is more about fearing eating because they're going to have some kind of a physical issue, then trying it out in a less triggering environment and bringing it back to the school. In school, we are again going to start with eating alone, eating with a smaller group, if they do okay. And sometimes they're going to say, I'm still having stomachache, I need to go to the nurse's station. Okay, that's fine. You're allowed 10 minutes, but then you come back. But continuing to increase the group, not letting them just eat by themselves, because from that is going to stem the another eating disorder symptoms eventually. What I see is kids have emetophobia where they don't want to eat, but fearing that either they're going to throw up or they're going to get sick at school. And then it resolves to, I don't like these kind of foods, and then that circle gets bigger and bigger, and then they don't like meat, and then they don't like dairy, and then they are like, if I eat, I'm going to hit the puberty, and then they want to avoid that. So that is the pattern you need to break. You want to include the wholesome, nutritious food, starting off with a smaller group, bringing it to the bigger group, but not promoting their social avoidance at all. All right, go ahead.
Question. Do you find that there could be environmental factors that can lead to a lot of the anxiety that we're seeing in children?
Absolutely, and I think I did mention some of those up here, that how sometimes how the parents are handling the situations could promote anxiety as well. Inhibited parents having their own anxiety can cause anxiety too, but then over-controlling, overly critical parents can cause a lot of anxiety in the child as well. So yes, environmental factors along with the biological factors are extremely important risk factors for our kids. Good questions there, yes.
What about bigger social influences? Because I feel like you put a very good point that I've been saying a lot, and it doesn't feel like anxiety is normalized as much anymore. Like that is, you can't have any anxiety, that's bad, and it's like it's normal to have some anxiety. And I don't know where that's coming from, and maybe you don't, but I'm just curious if you're seeing that.
And let me try to understand your question better, that there is anxiety, and anxiety is considered always as bad anxiety.
Yes.
So I think having those discussions, those open discussions with the child, more often than not, a 6-7-year-old child can also tell you that they are anxious or worried or how they are feeling. So you're having those discussions, you're acknowledging their issues, and then, hey, you have anxiety and you can't come back, or you have anxiety and you can't do this, should be avoided. So talking to the child, getting help is okay if you really need it, but this is a normal fear that every child has. Like, so if somebody is having thunderstorm fears, or if a child is fearing my parents are gonna die and they're never gonna come back at age 8, those are all real fears. Yes, they all can have those fears, but how do you say, what is the likelihood that this is gonna happen? It is very interesting that you said that, because me and my husband were just talking this morning about our kids, and how my almost 7-year-old child, who you just saw in the picture, was talking about, what if you never come back to pick me up from school? And then my husband had a very decent, interesting conversation that I was listening to, and he said, mostly we would come back, you will go to aftercare and we'll come back. And if we don't, if really something bad happens to us, these are the people who will be coming to pick you up. And let's say, Anya, if you really, if something happens to us, that we aren't able to come back to you, then your Bade Papa, who is my husband's brother, will be taking care of both of you until you guys grow up. So having those real conversations that there's a lesser likelihood that this is going to happen. We do have a plan if it happens, and hey, but there is somebody who is going to take care of you no matter what. And then, when this is beyond, no, how did you say that? You're not going to, okay, so then they're not able to rationalize and process, and then you help them through. And if If it is still not working, then you know it is not normal, right? And then you get them the help that they need. And when it is not normal, still saying a lot of people have these fears. And I understand you're worried, and I understand that it's not helping, but we are trying to get you help. Yes.
I do play a game with kids about fear and anxiety and whatever, and also things that do come up because I know I'm confident in them is school crisis, shooting. What if we have a phone red? Would that fix the problem?
We will.
That's probably a similar response that I can provide. And it might happen.
It might happen.
Very unlikely it's going to happen.
Very, yes.
That's probably the message that comes out.
Very well said. Thank you. Thank you. Yes, I absolutely agree. And like you said, I also see a lot of kids who are talking a lot about school shootings, not just the younger kids. I am hearing a lot more from 14, 15-year-olds